So we are going to start, and what we are going to talk about today is a very, very important topic for all of us, and it is an approach to fever. I hope you can see the slides, and so we will get started, right? So whenever we talk about approach to fever, uh, first is what is a fever? It is very important for us to define this, what is a fever, and then we can understand what it is like and what are the different types of fever, and we will talk about how to approach whenever a patient presents with a fever. As you all know that fever is one of the most common clinical complaints with which patients present in the OPD, in the IPD, in the emergency situations. And whenever a patient approaches with a fever, we have to then um, approach the patient with a particular set of clinical protocols and then arrive at a differential diagnosis and then arrive at a most likely diagnosis. Then we order a set of investigations which are going to confirm our diagnosis. In the meantime, we may need to start some empirical or presumptive treatment for these patients. And ultimately, once we have a final diagnosis, we then start with the confirmed or the final treatment for the patient and observe for a clinical response. So it is very important for us to deal with and talk about fever in great detail. And all of us have had a fever in our life. Sometimes it is an undifferentiated short-time fever. Sometimes it's a more prolonged fever, which has more far-reaching connotations. Whatever it is, we need to have a very, very clear approach to a patient with a fever. Today's session is just like that. What I'm going to do is in the initial, maybe about an hour or so, I will give you an approach to the patient with a fever in the form of this didactics. Then what I thought is that we will have a small case presentation by a couple of students who have volunteered to present the differential diagnosis of the case. And then we will end up with a small discussion about the fever. So getting started, what is a fever? So whenever there is an elevation in the body temperature that is above normal range and an increase in the temperature regulatory set point of the body, uh, these are the usual cutoffs that are given for a mouth. If you take the temperature in the mouth or the oral cavity at about more than 99.9 Fahrenheit, if you take the temperature in the axilla or in the ear of more than 99 and a rectal temperature of more than 99.5 or more than to about 100.9 is what is actually defined as a fever. So whenever there's an elevation in the body temperature above the normal range, which increases temperature regulatory set point, it is called a fever. Hyperpyrexia, on the other hand, is when body temperature is much higher. It is typically in the range of 104 to 106. And, and classically, hyperpyrexia is not caused by an infectious cause. So it is important to remember that when we try to talk about fever and hyperpyrexia. So let us look at one very important definition or one very important differentiation, and that is between fever versus hyperthermia. Let us see what is fever and what is hyperthermia. So whenever there is a resetting of the thermostatic set point in the hypothalamus, and this resetting of the thermostatic set point, which when it leads to a heat conservating mechanisms getting activated, so the body temperature internally reaches a new level, this is called a fever. If acute, it is usually because of an infection unless proven otherwise. This is a general categorization. Hyperthermia, on the other hand, is an elevation in the body temperature that occurs in the absence of a resetting of the hypothalamic thermoregulatory center. And this is just an important differentiation for you people to know about. So it is very, very important that whenever a person presents to the outpatient department or to the emergency department or as an inpatient, it is important to find out what is the cause of the fever. So all our exercise is evolved or it is pertaining to finding out what is the cause of that fever. So classically, fever can be categorized on the basis of duration into what are called acute or short duration fevers and long duration fevers or prolonged fevers, and a subcategory of that also called fever of unknown origin. Now, if you ask me what is this categorization, how much is short duration, what is long duration, it is very difficult because different research papers and different organizations categorize it in different ways. But the most common or the most general categorization on the basis of duration is that any fever which is say less than 15 days or less than 2 weeks duration is categorized as an acute fever or a short duration fever, and any fever which is more than 3 weeks classically is taken as a long duration or prolonged fever. So now you will ask me, madam, what happens to the fever between 2 weeks and 3 weeks? Well, it is not that it is not categorized. By definition, it doesn't fall into a short duration, and by actual definition, it doesn't fall into a long duration also. But any fever more than 2 weeks is more likely going into a prolonged fever rather than fitting into one of the diagnoses of short duration fevers. So why is it important to categorize it on basis of short duration or long duration? Because generally the etiologies or the conditions which present as a short duration fever or an acute duration fever are remarkably different from those that present as a long duration fever or a prolonged fever or an FUO. So if you know whether the patient is having a short duration fever or a long duration fever, then you are far more likely to be able to understand or to kind of categorize what could be the possible etiological conditions. So it is very important to categorize fever as short duration or long duration. So there are certain other important considerations in addition to the duration of fever, which we must consider whenever a patient presents to us with fever. The first and foremost is, of course, what is the type of fever? And we will talk about that in a little more detail in the following sections. And here we will try and tell you what are the different types or patterns of fever. Equally important is what is the setting or the circumstance or the risk profile of the patient who has developed a fever. For example, if a patient develops a fever while in hospital or while admitted for some other illness, it means it's a hospital acquired fever. If a patient is an elderly patient, a patient is immunosuppressed already on say he's a patient of post organ transplantation and is on immunosuppressive drugs, that patient develops a fever, then that circumstance is very different. So that is why the setting in which the fever develops and what are the circumstances or the risk profile of the patient who presents with the fever are very equally important to recognize. It is also very, very crucial to understand what are the associated symptoms. Many times, fever does not happen alone. It presents with multiple, small, minor, or major associated symptoms. For example, if a patient presents with a fever and a rhinorrhea and a sore throat, you know you're likely to talking about an upper respiratory infection. If on the other hand, the patient presents with fever, abdominal pain, and dysentery, you know we are talking about something related to the GI tract. So that is why trying and finding out about associated symptoms helps us in localizing the fever or the infection to a particular organ or organ system that again tries to narrow down the possibilities which gives rise to fever. And like I said, when you examine such patients with associated symptoms, if you are able to elicit specific clinical signs that help you localize the disease, that makes it even more easy to ascertain what is the cause for fever. So let us start with the type or pattern of fever. It may provide a very important clue as to what is the cause for fever. So classically, the fever has been categorized into continuous, intermittent, or remittent types. And there are small graphs on the left side, which I will try and show it to you. The first one is what is called sustained fever or continuous fever. As you can see here, the temperature remains above normal throughout the day, and the fluctuation in the temperature which is happening is less than 1 degree Celsius in 24 hours. So this is what is called sustained fever. We also call it continuous fever. In intermittent fever, on the other hand, the fever has kind of spikes, but the fever does manage to touch the normal in between these spikes. So it is important to remember that for a brief period of time, the fever does manage to reach the normal and again climbs up to have a high peak or a increase in body temperature. In remittent fever, as you can see, this graph is different from this graph. Here also, if you see, there is a rise in body temperature and the temperature does come down. But every time the temperature comes down, you find that the temperature is not hitting the baseline, which means that fever is persisting in this patient. The body temperature remains elevated, and the fluctuations in the body temperature that happen are beyond 1 degree Celsius in every 24 hours. So these are the three classical patterns of fever. Then there is something which is known as relapsing fever. So you have fever which lasts for a day or two, and then there is an afebrile interval after which the fever rises again, and so this is relapsing fever. Characteristically, you can see relapsing fever in malaria. For example, a patient will have fever for 1.5 days, and then fever settles down for 1 to 2 days, depending upon the infecting plasmodium. And then again, there is a rise in fever. So in between the two spikes, the body temperature remains normal, or there is an afebrile period. And of course, there is one very classical fever, which is called the pale Epstein types of fever, which is classically earlier described in Hodgkin's lymphoma, where the temperature remains elevated for a week, and then there is another week of afebrile phase, and then the temperature gets elevated again. So now it is, although these patterns and types of fevers can provide a clue, it is very, very vital to remember one thing, that nowadays we hardly get to see any specific type of fever. And the reason for that is the moment a person develops a fever, paracetamol is available as an over-the-counter drug. Most people would take paracetamol, and so the pattern of fever gets tremendously altered by medications. Not only paracetamol, patients also take multiple antibiotics. They would have visited multiple local practitioners who would have given them antibiotics, would have given them antipyretics, analgesics. So all of them are going to alter the pattern and classical type of fever. However, patients who have continuous or sustained fever will still tell you that till the effect of paracetamol lasts, patients have defervescence of fever. But then again, the moment after about 4 to 6 hours, again the fever rises again, which means that the paracetamol is actually ineffective in controlling continuous fevers for a long period of time. However, still, in patients who have not visited a doctor, in patients who have not visited any practitioner or taken an over-the-counter medication, if you are able to see a particular type of fever, you may get a clue to what is the etiology of the fever, depending upon the pattern of the fever. So it is always important to ask the patient, have you noticed any particular pattern, or what type of fever is it? Could you describe it to us in better terms? So what are the challenges that one faces, or as a practitioner we face, when we approach a patient who presents with fever? So the first challenge, of course, is that we should be able to diagnose the etiology or the cause of fever exactly, so that then we are able to provide appropriate treatment to the patient rather than shooting in the dark, which we tend to do many times. When a patient comes with 2-day history of fever or 3-day history of fever, we really are not able to narrow it down very clearly because it is not evolved. It's only a 2-day history of fever. So we kind of think, could it be malaria? Could it be dengue? So whatever, and we'll talk about that a little briefly. So you should be able to diagnose the etiology of fever very clearly. More importantly, and equally importantly, is when you have in the emergency situation or in an inpatient situation, you have critically ill patients who present with fever. So these are patients who have come to you with either short duration or long duration, it doesn't matter. But these are patients who present, say, in shock. These are patients who present or with low systolic blood pressure. These are patients who may present with hypoxia. These are patients who may present with altered mental status. So these three situations tell you that the patient is extremely sick and critically ill. So in this situation with fever, it becomes all the more important not only to find the cause of the fever very quickly and institute appropriate treatment, you also have to institute life-saving measures so as to resuscitate the patient. And in many of these situations, thinking about the most likely diagnosis, we also have to institute appropriate presumptive treatment. So these situations are very complex and very challenging. Then comes the question of ordering laboratory investigations in these patients. So, do you order all investigations? If a patient comes to you with 2-day history of fever, what all will you investigate? Or is it too little or is it too many? Suppose somebody has come to us with a fever of 2-month duration. Would we do everything right from a hemoglobin hemogram down to a PET CT? So how do you decide? And so this laboratory investigations, is it too little or too many, is one of the biggest challenges, especially when patients have a slightly more prolonged duration of fever. And then, of course, is a decision to start empirical or presumptive treatment based on the most likely diagnosis when you are really not able to reach a particular diagnosis. And then there is this small subset of patients who, despite whatever you have done, still do not have a cause for fever, and they are undiagnosed fevers. In many situations, the fever settles down, or in some situations, you are really not able to find out a cause for a fever despite having extensively investigated these patients. So these are some of the multiple challenges that are there when we approach to a patient who presents with fever. We will take the first situation first, which is acute undifferentiated fevers. So this is a very interesting phenomenon which usually happens in India during this time, that is in the tropical regions, in the months of say April to September, when we have a lot of patients who present with what are called acute undifferentiated fevers. So what is an acute undifferentiated fever? An acute undifferentiated fever is a definition which is a common cause of patients seeking medical care or medical help in India. Many times you will find, if you're sitting in the OPD, about a third of your patients will come to you with short duration of fever of 2 to 3 days, and then you don't know what to do. You really don't know what is the cause for this. It is typically seen between June and September, when you generally have multiple infections that are predominating in tropical countries like India. Acute undifferentiated fever is also known as acute febrile illness. Sometimes some people call it a short febrile illness. Somebody call it acute fever. You call it by these different names because actually there is no international consensus definition which says that this is an acute fever or this is a short febrile illness. But we find that many of us use any of these names: short febrile illness, acute fever, acute febrile illness, or just febrile illness or acute undifferentiated fevers. Traditionally, however, acute undifferentiated fever has been defined as fever of 2 weeks or shorter in duration, but some authors tend to go up to a duration of about 3 weeks to classify acute undifferentiated fevers or acute fevers. All right, so let us see further. Now, a number of viruses, bacteria, protozoans, rickettsia, all of them can cause acute undifferentiated fevers. Most of them will just present with a fever and some other non-specific symptoms or signs, which really do not provide great clues about the etiology. So the non-specificity of symptoms and signs is another important cause. For example, if you have a patient who presents with, say, fever of 3 days or 4 days with chills and rigors, and on examination you find that the patient has a spleen tip palpable. So now this patient could be having malaria, this patient could be having dengue, this patient could be having chikungunya, this patient could be having any other viral illness. So if you understand, although the spleen is enlarged and it's a localizing sign, it in this situation it still becomes a little non-specific because it really doesn't give you a diagnosis very clear cut. And also, in many situations and in many circumstances, there is a lack of availability of accurate diagnostics. So you're not really able to pinpoint what is the cause. There are multiple differential diagnoses, which often leads to the irrational uses of both antibiotics as well as antimalarials. And you will find this in our wards many times. You find that patient is on an antibiotic, patient receiving an antimalarial, is receiving an antipyretic, and so we really don't know what is happening. So we tend to treat for all because we are not able to pinpoint what is the cause for the fever. However, when acute febrile illness or short fever syndromes have a localizing feature, that becomes really helpful, and that really helps us. For example, if a patient has history or a clinical finding which points towards the skin and soft tissue, for example, there is an area of redness or there is an area of inflammation which you could think could be an abscess or a cellulitis, or there could be evidence of neurological or meningeal involvement in the form of a headache, neck stiffness, altered sensorium with or without focal neurological deficits. Or it may get narrowed down to the respiratory tract with the patient presenting with fever, cough, breathlessness, sputum production, chest pain, or it could narrow it down to the urinary tract when the patient presents with fever, with dysuria, with hematuria. So if you're able to find some localizing sign, it really helps you narrow down the differential diagnosis from that huge list of causes to a very small set of conditions which can present with these symptoms and signs. So that is why it is very important to repeatedly ask your patient all these signs. Even if their patient does not present with them, you have to take a focused negative history to try and rule out symptom involvement. Also, there are certain other patterns of acute fevers. For example, fever under rash, fever and myalgias, fever presenting with arthralgias, fever presenting with skin rash and hemorrhages, and fever which can have present with jaundice. So if you have these conditions here again, you will find that many of them have overlapping etiologies. But again, it does help when you have some localizing signs or some other syndromic signs which help you approach the patient in a much more easier manner. All right. So these are things that you should look for in any patient who presents with fever, and then try and narrow our differential diagnosis down. So I just tried to show this table to you. This is from a research study which shows some of the common causes of fevers which are happening across, and these are reports which have come from various different parts of Southeastern Asia. As you see, from Cambodia, India, Pakistan, entire Southeast Asia, and so there are numerous studies. If you see, there are different sample sizes which have been included, but the most common causes of acute fevers are malaria, salmonella, leptospira, rickettsia, other bacterial infections, dengue, influenza, other viral infections, non-infectious causes, and of course, there are many in which you are not able to find out what is the cause. So if you see, these are the most common causes of fevers where you are not able to get a localizing sign, or you are not able to have a really clear-cut condition. So this is the group of diseases that you're going to investigate thoroughly. Based on median prevalence of other etiologies, 20%, one-fifth of all acute febrile illnesses will end up having malaria. So malaria is one of the most important diagnoses to entertain in any patient who presents with a short duration of fever from a country like India. You might not probably think about malaria in non-malarious areas, but in India, you will definitely think of malaria as one of the most important differential diagnoses. Then another about 10% will have rickettsia, influenza, and another 5 to 10% will have dengue, enteric, leptospira, or Japanese encephalitis. And remember, to a large extent, this also varies on the season, it varies on the time, it varies on the geographical location, and also on the endemicity of the disease in a particular area. So, for example, now in the month of, say, July, August, if somebody presented with acute fever of, say, 3 or 4 days duration in Delhi, what are all the diagnoses we would consider? We would consider malaria, we would consider dengue, a little more prolonged fever, we would consider enteric fever, we can consider chikungunya, we can consider uh, other viruses. Of course, now after COVID, I mean, COVID is one of the most important diagnoses to consider now, but other viral infections. Then, in case you think that there is a local outbreak of, say, scrub typhus going on, then you will also like to think and entertain those possibilities. So that is what I'm trying to tell you. If you remember, a couple of years ago in Delhi, we had a minor outbreak of scrub typhus, and so you would still consider those possibilities accordingly. It is important to remember that even after applying a broad battery of tests, in about a third to a quarter of patients, almost 25% of patients, you really cannot find out what is happening. And in many cases, about after 4 to 5 days, the fever settles down on its own. Whether you have given the antibiotic, whether you have given whether it's because of the analgesic, whether it is because of the anti-malarial, you are never able to find out. But fever settles down, patient recovers and goes back home. And very variable proportions in a review in 2014, from 8 to 80% of patients, you were never really able to find out the cause for this fever. So like I said, Neither a clinical history nor a physical examination is accurate enough to give you a diagnosis. However, like I said, clinical features are really helpful in many situations. For example, you can have a fever rash syndrome, a fever jaundice syndrome, fever altered sensorium syndrome, or a fever arthralgia syndrome, where again, from the whole uh, gamut of fevers, you can try and localize one or the other into these groups, because these have different etiological agents responsible, and then you may try and investigate one of these particular causes. So let us look at some, how do you go about, once a patient presents to you with an acute undifferentiated fever, how do you go about that? So whenever a patient presents to you with an undifferentiated fever, which is less than 21 days, either it gets diagnosed or it remains undiagnosed, and anything beyond 21 also, if it is resolved, fine. If it doesn't resolve, many of them remain unresolved. So let us look at this protocol, which looks very complex, but it is not. But please try and follow the protocol along with me. Is the slide visible? I hope so. All right, because am I audible and is this visible? Anybody?
Yes, ma'am, we can see the slide and ma'am, we can hear
All
you
right.
too.
Thank you so much. So whenever a patient presents with fever, first rule out the clinical signs of severity or critical illness, which are anybody who has altered sensorium, anybody who is in shock with a systolic blood pressure less than 90 millimeters of mercury, or anybody who has tachypnea. So these are patients who are very sick and critically ill, and you need to evaluate them for systemic inflammatory response syndrome, and you need to manage these patients urgently. So your first priority will be to manage and resuscitate this group of patients who have fever. If you don't have a critically ill fever, then you will try to localize it to any organ system. For example, if it is cough and dyspnea, it is respiratory involvement. If it is headache, seizure, stiff neck, it could be CNS involvement. Dysuria, hematuria suggests urinary tract involvement. GI tract involvement is suggested by abdominal pain and diarrhea. And if there are abscesses and furuncles, it is skin and soft tissue involvement. So once you have found out or try to localize it to an organ system, then you will treat it accordingly. For example, if you have an acute respiratory infection because of cough dyspnea, you will treat it, and in the current scenario, you will try and look for COVID. If there is headache, seizures, altered sensorium, you will think of encephalitis, meningitis, and you will treat it. So that is the next thing you will do. Try to localize its symptoms. If there is also you're not able to localize it, try and rule out exanthemus fevers, meaning try and look for a rash. Sometimes a rash may not be evident on the arms or legs, so you will need to remove the clothes of your patient and do a very detailed examination. For example, an eschar may be found in very, very unusual sites. So you will really, really need to see whether there is any exanthem, and if it is there, you will need to find out the type of exanthem. And if I have time, I will show you some pictures of fevers with examples. Then look for jaundice. If you have jaundice, then it could be one of these: malaria, viral hepatitis, leptospirosis, drug-induced hepatitis, or hemolysis. And if it is there, then you have to go into that kind of a protocol. So now, if you have done all this and still you don't have any particular cause, then you investigate your patient for a short undifferentiated fever. But while you are investigating your patient, it is important that you need to manage your patient. He has come to you with a fever, you need to provide some succor for that. So you will give antipyretics like paracetamol to bring down the fever, and you will give plenty of oral hydration, advise hydration. And if you think your patient is mildly dehydrated or moderately dehydrated or is vomiting, then you can give IV fluids, and this will provide some symptomatic relief to the patient while you are investigating your patient. So the first thing you need to investigate is for malaria, and you are likely to do a complete blood count, which will may show you thrombocytopenia. You will do a peripheral smear examination, and then you will do one of the rapid tests for diagnosis of malaria. If you are able to diagnose malaria, please start malaria treatment algorithm. If, however, you are not able to get malaria, the second thing you should do is investigate for dengue. And the best thing to do is an NS1 antigen and also an anti-dengue antibody. If dengue is positive, treat accordingly. If no, then you will continue with antipyretics if the fever is less than 3 days, and if it is more than 3 days, we will see what we need to do further. So now we have done this, and the fever is beyond 3 days. Now, many times what happens is, during this period of 3 days, the patient will either develop a new clinical feature or show a new clinical sign. So remember, whenever you are dealing with fever and fever is not resolving, please re-examine your patient again and again to see whether a new localizing feature has developed or the patient has. Of course, you will keep on assessing the patient for critical signs. Sometimes patient may show a new clinical feature. For example, on the third day, you may now find a very soft spleen has emerged. So you will then think, okay, this was not there initially, but now patient is demonstrating a splenomegaly. So please try and look for new evolving signs, which always help you. Then your differential diagnosis after 3 days becomes one of these. Enteric fever is a very, very likely possibility. Leptospirosis in appropriate epidemiological conditions. Scrub typhus, other rickettsial illnesses, multiple viral infections, also enteroviral infections. For these infections, especially enteric fever, leptospira, you will obtain a blood culture. You will start doing a urine routine microscopy, urine culture, and at this point of time, you will get a chest X-ray done. So what it means is, generally a patient who comes to you with fever of 1 day or 2 day without any chest symptoms or without localizing to the respiratory tract, you should ideally not be getting a chest X-ray done on the first day itself, unless you're sure that it is a respiratory tract infection. Then you will start empiric antibiotic therapy while you await your clinical diagnosis. For scrub typhus, of course, you will like to send a wheal felix or one of the other specific investigations. If you think there is a strong suspicion of a rickettsial illness, in addition to the antibiotic, you should add doxycycline, and then you will investigate your patients appropriately. If the patient is not showing a clinical response, you will go with a higher set of investigations. So this is some approach to patients with acute undifferentiated fevers. It is important to note, always, like I'm overstressing this, but it is very important. Always ask repeatedly for associated symptoms or signs. Patients may not relate the two, but you have to relate associated symptoms and signs, because they will always help you localize the disease. It is best if you are able to use rapid diagnostic tests for the early diagnosis of malaria and dengue, and the WHO recommends that any patients with suspected malaria should have an RDT, and you should not wait for a peripheral blood smear, and that is very difficult to do also. And for dengue, NS1 is the best step after that, because the positivity appears on the first day of illness itself. And after that, you can, after about 4 to 5 days, you can start doing it with an IgM ELISA. And if you combine the two, the specificity, the sensitivity gets better. So if you, these are the three or four most important things that you would like to consider. And can use antibiotics alone if the fever is less than 3 days, where you're not sure of what is your diagnosis. And then you have to treat appropriately depending upon your most likely diagnosis for that patient in that particular scenario or circumstance. And if the fever is slightly more prolonged, then you would like to think of a bacterial origin, like for example, enteric fever in India, and then you will probably give empirical antibiotics. So that finishes the first part of my session, and that was acute febrile illnesses. Now I will go on to the next part of my session, where we are going to talk about prolonged fevers. All right? Is that all right? So what we are going to now talk about is when patients present with what is called fever of unknown origin. It is also called pyrexia of unknown origin, and initially it used to be called pyrexia of unknown origin. Now the more likely term that is used by everybody is fever of unknown origin. So fever of unknown origin, or FUO, by historical definition as given by Petersdorf and Beeson in 1961, was anybody who presents with a fever of 3 weeks duration, with a temperature touching 101 Fahrenheit or 38.3 degrees Celsius on multiple occasions during the 3-week duration, and no diagnosis was reached after 1-week evaluation in hospital in such patients. Remember, this was a definition given in 1961 where diagnostic techniques were not fully evolved. We did not have rapid diagnostic techniques. So the duration of evaluation was 1 week of hospitalization. But this formed the basis of the definitions of all the fever of unknown origin that we know about. Now, over a period of time, we have been able to categorize fever of unknown origin or prolonged fevers, FUO especially. This category was given by Durack and Strait, and these are the 4 classical categories of fever of unknown origin. The first category is nosocomial, meaning the fever is acquired within a healthcare setting, not a hospital setting, a healthcare setting. Neutropenic, when neutropenia is present in these patients. HIV associated means the patient is HIV infected and present with an FUO. And all other categories of FUO that do not fall into these 3 specific categories are classified as classic FUOs. So let us look at them one by one. Nosocomial FUOs happen when the patient is hospitalized in acute care or chronic care, and patient did not have evidence of infection when the patient was admitted to the hospital. For example, a patient of stroke gets admitted into the hospital with a stroke. Patient did not have fever when patient presented to the hospital, but 5 days after hospitalization, patient develops a fever. So that becomes a nosocomial infection. All right. The duration of illness, while investigated, see it has come down from that 1 week to 3 days. And the most common causes of nosocomial infections become, like, for example, in this group would be septic thrombophlebitis or catheter-associated infections, Clostridium difficile diarrhea, drug fever, and so on. Anybody who has a neutrophil count of less than 500 cell microliters, or somebody who has a falling neutrophil count that is expected to reach that level in about 1 to 2 days, again by about 3 days, is likely to suffer from diseases such as perianal infections, aspergillosis, candidemia, etc. And so this is another group of patients that you have to consider, severe fungal infections. Patients with HIV who develop prolonged fevers should be confirmed with an HIV positive report, and there are multiple causes of opportunistic infections that happen in these patients, and these patients can present as fever of unknown origin. Everybody else who presents with fevers for more than 3 weeks, which has not been diagnosed in three days or 3 outpatient visits, can have any of these infections, malignancies, inflammatory diseases, or drug fever, is categorized as classic FUO. So let us look at some of the causes of FUO. Whenever you see the causes of fever of unknown origin can be grouped into these 4 or 5 major groups. The first is infectious and inflammatory conditions. The second is connective tissue disorders. The third are malignancies. The fourth are drug fevers. And there are multiple miscellaneous causes which do not fit into any of these categories. So whenever a patient presents to you with prolonged fever, you have to try and find out which of these groups the patient actually fits into, or which of these conditions is causing the patient to have the fever. If you look at this graph or this chart, it shows you that what has happened to the etiology of fever over 40-year period. So if you see, this was the 50s, 70s, 80s, and 90s. If you see the incidence or the patients who present with FUO with an infection are going less. The patients who are having inflammatory conditions has almost increased. There are a lot of patients who continue to have no diagnosis as those who present with FUO. So if you see that infections are slightly coming down, but in India, infections still remain the most common cause of fever of unknown origin. So what are the infectious or inflammatory causes? We will take up the inflammatory causes first. I don't want to read this, but it is a very extensive list. For example, any inflammation anywhere in the body can present as FUO. It could be an intra-abdominal abscess, a liver, spleen, psoas abscess, any other abscess. It could be one of the appendicitis, polycystitis, tubo-ovarian masses. It could be an intracranial abscess, sinusitis, dental abscess, chronic pharyngitis, infective endocarditis, mycotic aneurysms, wound infections, osteomyelitis, pyelonephritis, prostatitis. These are some of the important causes of inflammatory conditions. Infectious conditions, remember TB, remember non-TB mycobacteria. Salmonella can present as prolonged fevers, including typhoid, listeria, actinomycosis nocardia, a whole lot of fungal infections. Cryptococcus, Sporotrichus, Aspergillus, Histoplasma, Mucor, all of them can present as prolonged fevers. Then there is a whole list of parasites, protozoans, malaria, babesia, toxoplasma, schistosoma, amoebiasis, trypanosoma, depending upon the clinical condition and epidemiology. And then there is a whole list of viral infections, for example, HSV, CMV, HIV, and so on and so forth. SLE, rheumatoid arthritis, giant cell arthritis, polymyalgia rheumatica, rheumatic fever, polymyositis, Wegener's. These are all some important causes of collagen vascular diseases which present as fever. Remember, many of them may also have associated symptoms and signs which could point to an etiology, but there may be many in whom fever is the only presenting feature. For example, polymyalgia rheumatica. For example, polymyositis, there may just be severe myalgias and a fever. So you should be able to identify these conditions. Many malignancies present as fever, the most important being lymphomas, but there are also certain solid tumors, for example, renal cell carcinoma and hepatocellular carcinoma, which just present as fevers. So in elderly patients where fever duration is more prolonged, please try and rule out solid tumors in these patients. There are multiple drugs which can give rise to fever. Alpha methyl dopa and quinidine are the most common implicated, but many times antimicrobials can also cause fever. We have seen this in our wards. Hospitalized patients are admitted for fever. Everything else resolved, but the fever doesn't go. If you stop the antibiotics, the fever will resolve in these patients. So drug fevers are an important cause of fevers in patients. And then, of course, there is a whole list of miscellaneous causes. One should reach these only one has ruled out all the other important causes of fever, and I have just put this list up here so as to complete the list of conditions which gives rise to fever of unknown origin. Again, there can be clues. There are important clues which sometimes will help you in arriving at a diagnosis. If the patient has gone out for hiking, hitchhiking in the months of summers and has bitten by something, then you could think of a tick bite and then think of a tick fever. If the patient is working with birds or has contact with birds or animals, you will think of one of these causes. If myalgia is a prominent symptom, think of conditions like trichinosis, polyarthritis nodosa, polymyositis. These are some of the important causes which present with severe myalgias. If there is headache, think of a CNS malignancy, chronic meningoencephalitis, brucella. All these can cause fever. If there is cognitive slowing or slowing of mentation, think of one of the tubercular meningitis, sarcoid involving the CNS, cryptococcal meningitis, a CNS malignancy, brucella, HIV, when there can be cognitive impairment. If a patient has cough with sputum production, then of course you will think of one of the infections that involves the respiratory tract. In India, you will always think of TB. Please try to think of TB before you think of anything else in prolonged fevers. Think of other complaints. For example, if a patient has severe fatigue in addition to fever, think of an underlying carcinoma or a solid tumor. Think of a lymphoma. Sometimes SLE, rheumatoid arthritis, they can, and CMV, they can present with prominent fatigue as an associated feature. If there is backache or back pain, think of brucella, culture negative endocarditis, and some of the other diseases like angstpon. If this situation is all right. So always look for associated complaints and associated histories. They may help you in providing a good clue to the cause for fever. So remember, infections are still the most common cause in India. They always, even worldwide, infections are the most common cause of prolonged fevers or fever of unknown origin. It is an important dictum to remember this. As the duration of fever increases, the likelihood of the fever being because of an infection decreases. So the more the symptom of fever is getting prolonged, the less likely it is because of an infection. It is more likely to be because of a malignancy, because of a connective tissue disorder, or any other disorder, because infections usually present with a shorter, not a short, but a shorter duration of fever as PUO rather than very prolonged, say for 1 year or something. Please remember, in the elderly patients, you must rule out a malignancy by doing all appropriate investigations. And in younger patients, you should always rule out collagen vascular or connective tissue disorders. And whenever you are approaching these patients or you are approaching a diagnostic protocol, always keep the geography in mind from where the patient has come. And that has a lot of implications on the causes for fever. As far as investigations are concerned, you saw the list of conditions which gives rise to fever. So you can do any and all investigations, but always be methodical. Don't order all investigations at the first go. Always get investigations as directed by the symptoms or signs. That is why the localizing features and localizing complaints become so important. Develop an diagnostic algorithm for yourself. So these are the first set of investigations I will get done. If that doesn't help me, then I will go further with the next set of investigations. Then I will go further with the next set of investigations. So always start with simpler, non-invasive tests. Like an ultrasound is much more simpler than a PET CT, which is far more complicated, far more expensive, and more difficult for the patient to access. So start with simpler investigations, non-invasive investigation. Attempting a biopsy is going to be much more difficult to convince the patient rather than to do something non-invasive. Remember, however, that invasive tests may be needed. It does not mean that if you're doing non-invasive tests, you will never need an invasive test. No, if you want a histopathological diagnosis, you will have to do an invasive test. So remember that may be needed, but you can kind of put that a little later once you're sure that that has to be done. Never forget, especially when we come from a background like ours, always keep the costs in mind. The more investigations you add on to your patient, especially if the patient is in a private setting or you are in any other setting where the patient has to pay for the investigations, always keep in mind the costs that have to be borne by the patients, and they can be very tremendous, especially when you're investigating a patient who has fever for a prolonged duration. So you will order a whole set of cultures and x-rays and CT scans. So it just adds on to the cost. So please keep your investigations very clear and directed towards the cause. And so you will then be able to judiciously use all investigations for your patient. I'm going to stop here. Uh, And I think I have covered two topics. I have covered an acute fever, and I have covered a fever of unknown origin, and I have covered that is one of the prolonged fevers. So I have more slides to show you. I have slides to show you regarding hospital-acquired infections or healthcare-associated infections. And I also have slides about some dermatological or skin evaluations in patients with fever. However, what I would like to do now is I would like to invite my three friends who volunteered to be part of today's program. And these girls uh, are going to present a case. And then after they present the case, they will present their differential diagnosis. And then what will happen is we will discuss the case in the light of what we have read till now. If we have time beyond that, which is possible, then I would like to take maybe one or another of set of slides. But if I keep speaking, then it really does not add value to today's lectures. So is that clear? Am I all right? So can one of Harshita or Anisha or Alicia, can one of you take over now?
Hello.
Uh, yes, ma'am. Ma'am, Bhavika will be presenting the slides, and Alicia will be speaking out the slides, and then Harshita and I will be discussing in between.
Fantastic. So can you go ahead and present your slides? Will that be all right?
Yes, ma'am.
Yes,
Yes.
Yes, ma'am.
You want me to stop my slides?
yes, ma'am. Stop,
I've
please.
stopped my slides. All right.
Ma'am, you will have to make Bhavika the presenter. She has to present her screen to show the PPT.
Do I do that? Is the question.
Ma'am, I am one of the presenters, but ma'am, I am not seeing the option to present my screen. I can only unmute myself at present.
I am also trying to find out how to do that. So webcams, sharing, start, change presenter. Okay. Uh, who should I make it as? Bhavika?
Yes, ma'am.
Yes, ma'am.
All right. Yes, Bhavika. Now I think you can present. Are you ready, Bhavika?
I'm still not getting the option to share my screen.
All right, but
Ma'am,
I
it's
I
showing it,
I have I have
showing
made
on
you a
my.
presenter.
Ma'am, I think
I
you
have
made
made
me
you.
the presenter. I'll try share my
Yes,
screen, but I don't, I
yes.
don't, I don't, I don't have the latest PPT. I'll have to wait.
Okay, should I make somebody else then?
Yes, ma'am. Ma'am, if you could try making Bhavika instead. I think you made Alicia the presenter. Acha, ma'am, she's sharing it. It's okay.
All right. Yes, I think I can see something. Good.
Hello,
Yes,
hello. Is the screen visible?
yes, yes, yes. Please go ahead, girls.
Okay, ma'am. So this is the case. I'll first be reading out the history and examination and investigations, and then we'll try to discuss some of the DDs which we have made. Mr. X, 45-year-old male, supervisor by occupation, resident of Delhi, had presenting complaints of fever since 1 year, changes in mood for 6 months, hearing loss for 6 months, backache since 4 months, generalized body aches and joint pains. The history of fever. Fever was low grade. It was not associated with chills and rigors, cough with expectoration, headache, burning micturition, or loose stools. Uh, Ma'am, some we have added some lines in the red because we thought that we didn't
They
have
are
enough
important.
information about this.
All right. Okay. So these are questions you want me to take up little later, is it?
Yes, ma'am, after we've finished the
All right.
presentation.
All right. All right.
Backache since 4 months, discomfort greater in the lower back, dull aching, no history of trauma, burning micturition, shooting pain in lower limbs. Progressively increasing bilateral hearing loss in the last 6 months, underwent bilateral Grome insertion in September 2013, which provided temporary relief. Hoarseness of voice since last 4 months, and generalized body aches and joint pains. The relatives give history of low mood since last 6 months, decreased interactions, decreased interest in previously pleasurable activities, decreased sleep. History of loss of appetite is present since many months without quantifiable weight loss. Patient denies history of diabetes mellitus, hypertension, epilepsy. He is on anti-tubercular therapy for last 4 months with no relief in symptoms. Patient consumes non-vegetarian diet. Bowel and bladder habits are normal. No similar complaints were obtained from any family member. Examination, the patient was conscious, oriented with time, place and person. Uh, his height is 180 centimeters, weight is 80 kgs, the BMI 24.1 kgs per meter square. The pulse was 76 per minute, regular. BP was 130 by 190 mmHg. Respiratory rate was 16 beats per minute. Pallor was present, JVP not raised, no lymphadenopathy. Scleritis was present bilaterally. No abnormality detected on the examination of chest, cardiovascular system or per abdomen. To summarize, fever for 1 year associated with backache, hearing loss, hoarseness of voice, mood changes, generalized body aches and joint pains, ileal ulcers, bilateral scleritis, essentially normal physical examination. So, hello? Ma'am, we are finished with the history and examination.
Yes.
So after the
Yes.
history and examination, we have a certain set of DDs.
Yes.
Uh, so uh,
So you had
this
some
is a case.
questions.
Yes, ma'am.
You had some questions, correct?
Ma'am, yes, ma'am. The questions regarding some of the history points which we thought that were a little less in
They
detail.
are important. Yes. So
We
can we go back and see? Can we answer some of them as we go by? All right. So you've started with history. So you've said it's low grade history, low grade fever, and you're asking me whether it is episodic or continuous and whether it is documented or undocumented. So this
yes,
is one very important question which the girl has asked, is whether the fever was documented or undocumented. Many times patients will present to you saying मुझे अंदर ही बुखार है और मुझे बुखार सा लग रहा है, but when you actually monitor their temperatures you will find that they don't have fever. So feeling feverish is not the same as having a fever. Feeling feverish could just be a manifestation of feeling fatigued, just feeling tired. It could be a manifestation that something you're not maybe even psychologically well. So the first thing to remember is always, always when patients come to you, always ask whether the fever is documented or undocumented. That is, has the patient measured the fever? So yes, in this situation, the fever was documented. The patient had measured the fever on numerous situations and on numerous instances, and the patient's fever was in the low to moderate grade multiple times over the past few months. Many times patient has documented it. So that is one thing which is good question to ask. And the patient was having fever. Is it episodic or continuous? Well, we were not able to find out whether it is episodic or continuous. It was more continuous in the sense that patient had fever, would take an antipyretic, the fever would subside. Then after a few hours or maybe a couple of days, again patient would have a fever. So in that way, patient was having fever for the last few months. But there were episodes or there were periods in between when patient was afebrile for a couple of days, maybe 1 or 2 days, and again the fever developed. That happened initially, but later on towards say the last few days, the patient continued to have persistent fever, but each time the patient took antipyretic, the fever would come down to a certain extent. All right?
okay, ma'am.
Yes.
Ma'am, for the backache, there was a doubt about why burning micturition ka history was asked.
Okay. Why it is asked that is many times when you have patients having pyelonephritis, they can have a kind of a back pain, which does
जी
not,
ma'am.
when you ask about back pain, it does not always mean the spine. It also means the paraspinal areas. So whenever you ask about, when you are looking for pyelonephritis, it is in the paraspinal areas, isn't it? So that is why you will ask about history of burning micturition, because patients tend to have back pain there also. So that is what we were trying to rule out.
Okay, ma'am. Ma'am, the progressively increasing bilateral hearing loss. So, at this point, in further investigations, we saw that it was a mixed bilateral hearing loss. But here, we don't know that whether why there was a grome insertion and matlab, this portion of
We don't know,
information.
doctor. This is what information we also got. We were told that patient has had a grome insertion, so we also thought that maybe there was some serous or sero serious otitis media which happened in the past, and so that Grome led to some relief. But now for the last 6 months, it has been progressively increasing again. So whether it is a manifestation of the same disease or whether it is some new other manifestation, we were not sure. But that event was that, and we were not able to relate both these events, the event in the past and the current event.
So the piece of information is sort of incomplete as of now.
So,
So,
so
ma'am,
yes. So remember, many times what happens is patients in such situations, since you are taking so much history from the patient, because you're not able to kind of find out what is happening, many times you will get complaints or histories which you are really not able to correlate with the current illness. So put them aside, park them in an area and see whether they are relevant or not. Many times they may be relevant, many times they may be just red herrings, irrelevant. So this Grome insertion may or may not have been relevant. We don't know. We will just park it there and see whether we are really able to explain it at the end with all our differential diagnosis. All right.
yes, ma'am. Ma'am, for the hoarseness of voice, we wanted to know whether it was a sudden onset hoarseness or it was an insidious onset hoarseness. For example, was it after he had a episode of shouting or something, or whether it was an insidious onset chronic problem of hoarseness which has been progressing?
Yes. So this patient had a more slowly progressive hoarseness, and there was nothing specific which happened or which triggered or which precipitated the hoarseness. So what we know of is this, that over the past 4 months, patient was having hoarseness of voice, which was appreciated well by the patient as well as by the attendants. And we don't know because the patient did not show to any ENT person. We are not sure what was the cause. We will have to investigate that further.
Ma'am, for the body aches and joint pains, this was the piece of information which could have really helped us in ruling out some things. What was the pattern of joint involvement? Was it a small joint or a large joint involvement? Was it progressive migratory? And the duration is also kind of not given.
All right. So whenever a patient comes to you with joint pains, all right, first there are two things here. One is body aches and the other is joint pains. So we have to take both these things separately. Whenever a patient comes to us with joint pains, the first thing that we have to rule out is whether it is evidence, whether there was evidence of arthritis or whether there was just arthralgias. So the question that we need to ask patients under such circumstances is, in addition to the pain, did you ever notice any swelling in any joint? All right. So if there is arthritis, then that has different set of connotations and that completely changes the pattern of the disease. Arthritis, once a patient has evidence of visible swelling, then you think whether it is an inflammatory arthritis or non-inflammatory arthritis, and then you dig deeper to find out whether there is any specific pattern to the arthritis. For example, monoarthritis or polyarticular arthritis. After you have confirmed that there is arthritis, so you have to inquire whether there was joint swelling or not. In this situation, there was no joint swelling. The patient only said that he is been feeling aches and pains in all the joints, which means that there was just only a arthralgia. Your screen vanished.
Oh, yes, ma'am.
Your
Sorry.
slides vanished. No problem. We are waiting.
Ma'am, is it? Sorry.
Yes. Now it's come back again now.
Yes,
Yes.
ma'am.
So in this situation, it was only an arthralgia. Remember, arthralgia, like body aches, can happen in multiple conditions. So many infectious diseases, so many non-infectious diseases can present with arthralgias. And so one has to really understand whether the arthralgia is a leading symptom or it is just one of the manifestations of a chronic condition where so many patients can have arthralgias. So here, since patient did not have evidence of joint swellings and there was no evidence of arthritis on examination as well, there was no joint involvement, there was no evidence of any swollen or tender joints, we will go and take it that there was no arthritis whatever pains there was, or muscle pains or body aches or joint pains they were only arthralgias. And since when? Well, the patient did not give us an exact time that since, but he says, yes, over the last few months, I have been feeling generalized body aches and pains. No specific distribution, but I just feel that everything is aching. That's all.
Okay, ma'am. Ma'am, in this point, the thing is that relatives are giving the history of low mood, so that means it is significant that relatives have noticed. We just wanted to know whether there was a case of, whether there was an episode of unemployment or something, there was limitation in daily work life, which would further
So yes,
corroborate that this is a significant complaint.
yes. So this was a significant complaint in the sense that the relatives noticed that he was feeling a little low, and he had restricted his social interactions. However, that did not affect his work or affect his day-to-day life. He had no suicidal ideas, no suicidal ideations, so he was feeling a little low. So now whenever patients present with such complaints, there are two aspects to it that we have to think about. A, is it part of the primary process, in the sense that is feeling of depressive symptoms or having depression or low mood or all this part of the problem itself? Is it a primary problem? Or the second aspect, which is equally crucial, is somebody who is unwell for a long period of time will invariably have some amount of depression, that I'm not getting well, I'm feeling so ill, it's been more than a year, but my problem has not gone. So that
Yes.
itself leads to feelings of depression and low mood. So you have to really, really think that it could be both cause as well as effect. So that is something that you have to contend with. All right.
Yes, ma'am. Ma'am, history of loss of appetite is there without quantifiable weight loss, so this could be in this we had a doubt that whether there was loss of appetite for um, m- I mean, yeah, it says since many months, so yeah, loss of appetite is there, but there's no quantifiable weight loss. So how does that actually, is it a common thing to occur?
Uh, unless the appetite loss is very significant, if the appetite loss is significant, there will be a commensurate weight loss, which means that patient's loss of appetite was not very prominent. Maybe it was all part of the feeling low. Instead of
Yeah.
taking 3 chapatis, he was taking 2 chapatis. He did not feel like eating. He would just miss a meal. But it was not very significant because he had not quantified any weight loss or demonstrated any weight loss. All right. The next
Yes,
thing
ma'am.
here is the whenever patients present with fever, you must always ask them specifically. Remember, they will not tell you, are you taking drugs for treatment of TB? Invariably, if somebody goes with a history of 15, 20 days, history of fever to any practitioner, and he is not able to find out the cause, many patients are put presumptively on TB treatment, thinking
Yes,
it could be TB.
yes,
All
ma'am.
right. It is very
Yes.
important. That is why this patient also has been on anti-tubercular treatment for the past 4 months. Somebody put him on ATT because he was having fever for a year. So they thought it is best to give him some TB treatment for 4 months. All right. But remember here, there's one thing which is very important is despite being on ATT for 4 months, it did not provide him any relief. That part of it is very important and critical to note, which means that most likely
Ma'am,
it is.
we had a doubt over here as well. So it could be
Yes,
that the patient is not having TB, or
yes.
maybe it is some form of miliary or extrapulmonary TB, which will require more time to respond.
Most
But then again,
tuberculosis,
4 months is
yes,
a significant duration of therapy.
yes, yes. Patients, whenever we look for clinical response to anti-TB drugs, we look at about 6 to 8 weeks, maximum 12 weeks. I mean, that's a stretch. So by 6 to 8 weeks, invariably, most patients with tuberculosis who are started on optimal and appropriate ATT will show a clinical response. So somebody who has not shown a clinical response to that drug in 4 months, A, does not have TB, or B, has some form of TB which is not responding to those drugs, means it
It
could be
could
an
be
MDR.
yes, ma'am.
Yes. Okay, so these are the only two possibilities that you have to consider. A, he does not have TB, or he has MDR TB. But remember, a patient who has no significant weight loss, has no other clinical feature, chest is clear, abdomen has no organomegaly significant. Do you think that will be MDR TB without the clinical sign?
It is very unlikely because the further
Very
investigations have shown
unlikely.
that there was no signs or no
Yes.
findings which corroborate with him having TB
Yes.
in any of the
TB.
organs.
So, yes. So, this history that the patient was taking ATT in that way becomes extremely significant to us. All right.
Yes, ma'am.
Let us go further and see what is happening.
Ma'am, in the examination, the significant finding include pallor and bilateral
Yes.
scleritis.
Yes. So remember pallor, and this was moderate kind of a pallor. If it was severe pallor, it would have been written as severe pallor. It was a more mild kind of a pallor, mild to moderate pallor. Any fever which presents for a long duration. So many conditions, chronic illnesses can give rise to mild to moderate pallor, and so that way that pallor becomes significant. And the patient had bilateral scleritis. Now you have to examine and find out what could be the cause of bilateral scleritis, and we will then evaluate that a little later.
Yes, ma'am.
So
Ma'am, so
also there was no, yes,
ma'am, in the summary, there
go
is
ahead.
a line mentioned ileal ulcer. So we don't know that whether whether there was an endoscopy done and then the ileal ulcers were found, or is the patient giving history
Actually,
of
no, no,
some
no.
treatment?
This, sorry. Yeah, I'm sorry to interrupt you. This ileal ulcer, the patient had given a history that about 6 years ago, the patient had had some abdominal pain and was found to have ileal ulcers at that time. So this was the past history. Then we did not understand what was the cause of it, and we did not have any documentary proof of this also. So we had to take it with whatever the patient told us. Okay.
Okay, ma'am. Ma'am, so
Yes.
after the summary, this is a case of a febrile illness without apparent localizing signs and symptoms. So we have in mind, if although it is a 1 year history, but still we have considered TB extrapulmonary disseminated. It could be the patient is having maybe HIV because we did not see any HIV investigations in further. It could be a subacute infective endocarditis, brucellosis, but very less likely. Rheumatological causes, we have kept rheumatoid arthritis, vasculitis, SLE, ankylosing spondylitis, adult onset Still's disease, mixed connective tissue disorders, reactive arthritis. And granulomatous diseases, we have kept inflammatory bowel disease and sarcoidosis as one of the DDs after history and examination. Neoplasms and paraneoplastic syndromes, in this category, we would like to further investigate for any lymphomas or carcinomas with unknown primaries, and some miscellaneous disorders like amyloidosis or familial Mediterranean fevers. After investigations, we would further narrow it down to
So you would like
catch.
to discuss your differential diagnosis a little later, correct?
Yes, ma'am. Once we have also seen the
Have some
investigations. Then
investigations.
everyone, four of us, we have prepared a few uh, points in
DDs
favor
for
and points
yourself.
again for our DDs.
Perfect. Perfect.
So
Perfect.
in the
All right.
investigation, the significant investigations include a hemoglobin of 9.9 milligrams per deciliter, and TLC, DLC seem normal. The ESR is raised, and there was a spike in ESR in between. The serum creatinine is on the border, and the AG ratio is also altered slightly. The albumin is slightly lower than normal. Rest all are normal. On the imaging studies, ultrasound was normal. Chest X-ray had evidence of old pulmonary clots, nothing more significant. Cervical spine X-ray suggested spondylosis at the level of C5, C6. CCT had multiple lesions of decreased attenuation in bilateral lower lobes, subpleural bullae, oval-shaped lymph nodes in aortopulmonary window. So, ma'am, this chest CT was a very difficult thing. We could not really actually understand how to interpret these findings.
Interpret. Okay. Okay. You can go further, then we will discuss it.
Yes, ma'am. Okay, ma'am. CCT neck had no abnormalities. The MRI lumbosacral spine showed mild lumbar spondylosis with a grade 2 or 3 disc degeneration, with mainly annular tear and disc protrusion at the level of L4, L5, causing mild thecal sac indentation. So the findings of chest and X-ray and CT showed fibrotic shadows in bilateral upper zones. Left hilar prominence was there, probably vascular. No significant bony lung parenchymal lesions. No pre-parahilar or mediastinal adenopathy. No, the cardiac shadow was normal. So the left hilar shadow, probably vascular, was there. There was subpleural blebs, possibly the patient is a smoker or had COPD. No adenopathy, no reticulonodular shadows or ground glass pattern on CT. The heart was normal. And in the X-ray lumbar spine, an MRI lumbar X-ray had maintained lumbar lordosis, normal vertebrae, intervertebral disc space was normal, the SI joints was normal, osteophytes were present. MRI showed a hemangioma at T2, normal vertebrae, the disc prolapse at L4, L5 was there. More investigations, echo, ejection fraction was 55 to 60%. I don't know how to, what is RWMA?
Regional
RWMA
wall
is
motion
regional wall motion
abnormalities.
abnormality.
Okay. No regional wall
Motion
abnormalities, no
abnormality. Meaning there was no LV abnormality. The LV was contractile and moving well.
moving. No LV diastolic dysfunction. The MAN2 was negative. RA factor was positive. Vitamin D3 levels were low. Normal is 20 to 40 nanograms per ml. The PTH value was low normal. Serum ACE was normal. The patient was referred to ENT for evaluation of hearing loss. On indirect laryngoscopy, patient was found to have left vocal cord palsy with compensation. No evidence of growth or irregularities. On a previously obtained pure tone audiometry, patient was found to have mild mixed hearing loss. So the patient has anemia. The peripheral blood smear and RBC indices were normal. No other cytopenias. So this could be anemia of a chronic condition, or it could be some hematological malignancy. The ESR was raised, MAN2 was negative, vitamin D, PTH, and alkaline phosphatase were normal. Ma'am, further, these were the investigations which we thought that might have also helped us. So the blood culture, we don't have reports for any blood cultures, ferritin, LFT proteins, and electrophoresis, LDH, creatinine kinase, creatinine, electrolytes, urea, urine routine culture and microscopy, ANA levels, and that, and also these are, some of them were already done. Some which we've written in blue, we thought might have
You
helped
wanted
further.
more.
Yes,
All right.
ma'am.
All
Ma'am,
right.
and
So
from here, I would like
yes,
to hand over to Harshita to discuss the infectious DDs, whether they fit into this picture or not.
perfect.
Good morning, ma'am.
Good morning, Harshita.
We have basically looked at the history and examination, and then we also showed what were the findings on the investigations. So basically, when we looked at the history and examination, we did not have a very good lead as to where it could be leading, and there were a lot of question marks in our mind. So considering that, we kept infectious diseases because it's a common cause in India, and the infection that tops the list is tuberculosis. So I kept tuberculosis because on the basis of just the history and examination, when we look at it, we had a low-grade fever for a year. So it could point to a chronic infection like TB. The patient was a resident of India, which itself is a good point to keep TB. We had a multi-system kind of involvement, because when we looked at the GIT, we could see some ileal ulcers being present. There was hoarseness of voice on history with not much information, so it could be laryngeal involvement of TB. And the backache at that time could be because of osteomyelitis, which could again be due to TB. So we were looking at a disseminated TB kind of a picture. And we had a loss of appetite. Though the thing that was not much in favor was the loss of appetite was not associated with a significant weight loss. Though if we have TB in mind with a history of 1 year of fever, significant weight loss should surely have been present. So that was one thing that was not in favor. And as we had already discussed, that there was no response to ATT. So the response to ATT which was not present could be either it could suggest an alternative diagnosis or a drug resistant TB, as the ma'am
Yes.
already said.
Yes.
Uh, then when we went on for the investigation, so we started to get a lot of findings. Like for the backache, I'll start with that. So the backache we attributed, according to me, was due to the disc prolapse and the disc degeneration that was present. So hence we did not exactly attribute it to the main pathology that was going on, and we put it kind of separately. So that was the bone involvement was not due to the infective process, in my opinion. And also when we did the CT chest and the chest x-ray, there were no features of active TB that were seen. If I'm looking at a miliary TB, it would be some miliary mottling would be visible, and there was no such sign. Only a old pulmonary focus, old gone focus could be seen. And also, as I mentioned, that the patient was still well built. The BMI was 24, and the weight was also good enough. So that was also not going in favor of TB. Whereas few points which are almost similar as with the history were that there was lymph node enlargement seen in the aortopulmonary window, which could be due to TB. And the nerve involvement, as we saw that on indirect laryngoscopy, we have a recurrent laryngeal nerve involvement, which could be due to the lymph node impinging on the nerve, as the nerve forms a part of the aortopulmonary window. And so then large lymph nodes could do that. That's the best I could figure out. And so the mood changes that were present, I attributed it to the depression, which was relating to a chronic illness. So it was an effect more than a cause here. And if you wanted to see whether hearing loss was attributed to TB or not, we should have done an otoscopic examination to see the characteristic changes of a TB otitis media. And we would see multiple defects in the tympanic membrane, which could signify that the hearing loss could be attributed to TB. Again, the additional investigations to reach the diagnosis or to confirm that yes, it was not a TB. We could have done a sputum examination, and we could have done a nucleic acid amplification, which is the confirmatory test for a disseminated TB. And because we had an ileal ulcer, we could have done a biopsy from the edge so that we could see some characteristic findings of the gastrointestinal tuberculosis. So that was my take on TB.
TB. Okay, can I interrupt you here?
Yes, ma'am.
So perfect. So what you have described as TB as one of your most important differential diagnosis is very well taken. And the fact that you have highlighted the fact that he has not responded to whatever ATT was given to him, and patient was very well preserved despite being ill for more than a year. I think that is a very tremendous observation to make. Patients with TB untreated are not going to be very well, isn't it? They are going to lose weight,
Yes,
they
ma'am.
will become more ill, they will go downhill. And most importantly, all your investigations, your CT, your MRI, nothing picked up any focus of active TB.
Exactly.
All right.
Yes, ma'am.
So such a hidden TB for 1 year, which is not manifested anywhere, is a little unlikely. All right. And
Right.
sputum CBNAC would have been done if he was expectorating. He was not producing any sputum. So from where would you do a CBNAC? Right. And this ileal
Yes,
ulcer was there 8 years ago. So it was not there now. So we have to take it as a past history. We could not find any active ileal ulcers. So for us also, TB was a little difficult to explain because neither the physical features nor the investigations pointed to any real source of TB. Very good.
yes, ma'am.
So TB is high on your list or low on your list?
Ma'am, it was low on our list. That's why the investigations were not
Very
done.
good.
Yes, ma'am.
Very good. Go ahead. Next.
Yes, ma'am. So then we come to the next infection, which was HIV. So we thought this was missing in the investigations that were performed. So HIV could be presenting as, first of all, it could be a cause of underlying immunosuppression, which could lead to TB. So TB in the background of HIV could be present, or because the patient had a persistent fever, which was for 1 year. So in the clinical staging of WHO, stage 3 has a persistent fever for more than 3 months. So that could kind of fit in here. And HIV could have then several other multi-system involvements. So not very clear, but I would really like to rule out HIV. So HIV testing should be included, in my opinion, in the workup of the patient.
So perfect. So since patient was having fever, which did not have any particular localizing feature and sign for 1 year, we also kept a possibility of HIV. The patient had also been tested earlier for HIV, and when the patient presented to us in the hospital, we repeated the HIV test and the HIV was negative. The patient was negative for HIV infection, but your differential diagnosis of including HIV in this patient is absolutely correct.
Okay, ma'am. Yes. Ma'am, just for everyone who's listening, like the other attendees, the case was given by ma'am, and we've just given the differentials. Matlab, we have not made the case on our own. So everything was given by ma'am.
So I just wanted
And
you to tell me what are your differentials. That is the most important thing in the patient, isn't it? In this patient, in
yes,
this case.
ma'am. Yes, ma'am.
Yes,
Yes,
go
ma'am.
ahead.
So the third differential that we kept was under the infections. The broad heading of infections was infective endocarditis of the subacute type. We had a fever, we had arthralgia, which could be due to an immune phenomenon seen in infective endocarditis. The hearing loss, the best we could explain was it could be an embolic phenomenon. And had the neurological signs and the mood changes been a cause been a part of the infective process, then even neurological signs are a presenting feature of infective endocarditis. And then when we did the investigation, the ESR was high, we had anemia, and we had a RA factor positivity, which again fits in a minor criteria for infective endocarditis. But then what we were a bit apprehensive, because the echo that was done, that was absolutely normal. So echo forms a part of the major criteria in the modified Dukes. So that was ruled out. And there were no peripheral stigmata of infective endocarditis, like any of the Janeway lesions, the osseous nodes, neither did we have any of the eye signs like Roth spots or even conjunctival hemorrhage. So that just put us kind of on a back foot for infective endocarditis. And one thing that we needed for a major criteria was a blood culture. So we did not exactly find a blood culture being done in the investigations. So we thought that a blood culture would be good, like if we wanted to rule out infective endocarditis. And also there was no history of predisposing features which was seen. So that also kind of ruled out one of the minor criteria. So for infective endocarditis, we have the modified Dukes criteria, and in the major criteria, we have a positive blood culture or a echo finding. And in the minor criteria, we basically have 5 things, out of which if 3 are positive, which is either fever, an immune phenomenon, a vascular phenomenon, or we have a predisposing factor. If if 3 of these 5 and 1 major would have been positive, then a definitive diagnosis would be made of infective endocarditis. So we actually had some information lacking, and we had a negative echo. So we did not exactly, that's why I go much in favor of this, but we did not exactly rule it out also.
Right. So IE is a very important differential diagnosis to consider in any patient who presents with slightly prolonged fever. However, like she rightly said, there has to be an underlying cardiac disease for patients to develop IE. IE does not normally happen on native valves. All right. That means the patient does not have a diseased valve. It does native valves. So for a patient to have native valve endocarditis, the endocarditis that happens in such patients with native valves are usually acute endocarditis, and they are usually like staph, and they present with very toxic features. For somebody to present with subacute infective endocarditis on a native valve is a very remote possibility. Most often, Subacute infective endocarditis happens on diseased valves or deformed valves. And that we know, and we saw that the echo was showing
Was
structurally
normal.
the heart was normal, meaning the valves were normal. So IE as a possibility and did not reveal a vegetation also. It should have revealed a vegetation. But remember, sometimes vegetations can be very small, and if your index of suspicion of IE is very high, then in that situation, you should go ahead and get what done?
Ma'am, blood culture.
Okay, you will send a
Transesophageal.
blood culture. Absolutely.
And
You should then go ahead
transesophageal.
and do a transesophageal echocardiography so that some endocarditis vegetations which are not visible on a dorsal window on a 2D echo are visible on a TEE or a transesophageal echo. However, here again, like you said, we were not very sure that patient was having IE. So we kept it on our possibilities, but a little lower, and TEE would have involved an invasive echo. So we kept that possibility that we will get it done a little later if we were not reaching any other conclusive evidence. All right. But yes, it is a
Yes,
very good
ma'am.
differential diagnosis to entertain. All right.
Yes,
You go
ma'am.
further.
So the last thing that I thought of in infections was brucellosis. So
Hmm?
brucellosis does present in an old person with a backache and a long fever. But
Hmm.
one thing that was missing or something was that brucellosis has a characteristic undulating pattern which was not present here. That's why I wanted
Hmm.
to know about the pattern of the fever in the beginning, that
Hmm.
whether it was like continuous or a bit undulating. And also there was
Hmm.
no positive history as such ki animal contact hai ya fir even occupational exposure was not present
Not
as
there.
he was a supervisor. Yeah. So I
Yeah.
kept it very lower down.
All right. Perfect. We can go further.
Yes, ma'am.
Yes, ma'am.
So the next part will be taken up by Anisha.
Very good.
Yes,
Yes,
ma'am.
Anisha.
Good morning, ma'am.
Good morning.
Ma'am, in the next we kept inflammatory bowel diseases. Ma'am, in this case, actually, we initially thought ileal ulcers was one of the presenting feature.
All
So
right.
we had
All
thought
right.
keeping ileal ulcers in present. But even if it is in the past, then also it will slightly go in favor of inflammatory bowel disease here. So, ma'am, when we were
All right.
thinking of the yes. When we were thinking of the history, the supportive findings was that this patient is having 1 year of low-grade fever. And then we said that the patient also had ileal ulcers, which now in this case had happened 6 years back. We don't know the reason why. The patient has scleritis, which goes a lot in favor of such autoimmune conditions and granulomatous conditions. Crohn's disease is very commonly associated with uveitis and scleritis. Even ulcerative colitis is also associated to some extent. Then, ma'am, we have a history of joint pain, though it was not arthritis exactly because we did not have the history of swelling. So we thought probably it could be an inflammatory bowel disease associated polyarthropathy or some peripheral arthritis associated with it. Even the backache that could be there, that was there in the patient, could be explained by underlying sacroiliitis. We were not sure of. We needed further investigations for it. Generalized body ache, loss of appetite, low mood. Low mood is very much present in Crohn's disease and ulcerative colitis because of the long history of disease in this patient. And hearing loss in this patient, we could probably explain because this patient had mixed hearing loss. So, which means he also had a component of sensory neural hearing loss. And ma'am, sensory neural hearing loss is is one of the most which means if supposedly in autoimmune patient does have to have a hearing loss, the patient can have it more likely towards the sensory neural hearing loss with some features of the middle ear compartment getting involved. For that, maybe he was given Grome initially because of the minor middle ear compartment involvement. But then one finding which does not go in support is that he did not have any bowel symptoms here, which is very unlikely for a patient to have inflammatory bowel disease but without any bowel symptoms. But then here we thought that probably this patient could have presented with some form of silent inflammatory bowel disease. Also, ma'am, host, in the hoarseness of voice, we were thinking that hoarseness of voice could be because of two things. Either it could be because of vocal cord granulations, or it could be recurrent laryngeal nerve impingement. Ma'am, in the history itself, we did not know that it was a recurrent laryngeal nerve impingement. So, hoarseness of voice because of vocal cord granulations could have gone in favor of inflammatory bowel disease. But hoarseness of voice with recurrent laryngeal nerve involvement does not exactly go in favor. And then there is no history of weight loss also. So, that also goes against our diagnosis. But then on the investigations, anemia definitely goes in favor. Any chronic disease will have anemia here. Spondylosis, could it be that the patient is having some form of ankylosing spondylitis associated with it? I was doubtful about it. The patient had vitamin D3 level decreased, which is considered to be a risk factor for inflammatory bowel disease. And the patient also has elevated ESR. But the feature which is not going against in investigation is that the backache, which we thought initially to be of sacroiliitis, there was no sacroiliitis there. And also on indirect laryngoscopy, we found that the hoarseness of voice was not due to granulations. And lymph nodes in the aortopulmonary window is a bit unlikely to explain with inflammatory bowel disease. So, ma'am, that's why we kept it a little lower down after all the infectious diseases. And ma'am, additional investigation that could have helped us is that definitely we would want to go for certain confirmatory investigations. But one simple screening that could be done was the fecal calprotecting that could have helped us to screen inflammatory bowel disease. Apart from that, now the patient does not have the ulcer, but had he presented with the ulcer, we could have had a CT abdomen and ileocolonoscopy along with the biopsy of that.
All right, so that is a perfect description of inflammatory bowel disease. But like you rightly said, clinical history, there was no history of any diarrhea, loose stools, blood in stools, abdominal pain, nothing, nothing at all. There were no bowel symptoms. So, in the absence of bowel symptoms, keeping it as something silent IBD, it can be kept when there are two episodes, and then you know that probably the patient is in remission in between the two episodes. Then you can consider it if you have two well documented episodes of IBD. But here there was no documented single episode of IBD, and you have rightly pointed out there was no weight loss. Somebody who is having fever for more than a year and has bowel symptoms or has IBD would have had some features suggestive of malabsorption somewhere, whether it was Crohn's or whether it was UC, would have had some weight loss and would have had some other feature suggestive of malabsorption, especially if patient had Crohn's. However, we did not have any such clue on the history, and the examination also was not very specific. The investigations which were done did not point towards any IBD, and you're right. The absence of sacroiliitis, there was some small annular tear in between L4, L5. So that was really not very specific for IBD. So we also did not really consider IBD as one of the differential diagnoses. All right, very good.
Yes. Ma'am, next in the disease, we had thought sarcoidosis. Ma'am, I'll admit we were a bit biased towards it from the initial, but then later on it went down our list. Ma'am, because here this patient is presenting with low-grade fever, a lot of myalgia, a lot of generalized body aches, fatigue. Ma'am, these are very common features of people presenting with sarcoidosis. They do not have much localizing symptoms. This patient also had scleritis, which also is one of the reasons for sarcoidosis. And ma'am, this patient has hearing loss. We don't know. Probably it is because of multiple cranial neuropathy in this patient. The hoarseness of voice, we thought probably it could be because of the infiltrative vocal cord disease. Low mood, we thought probably if we could have asked further, if he is having some cognitive changes, it could have gone in favor of neurosarcoidosis. And we have seen that, ma'am, loss of appetite without weight loss is a very, ma'am, has been mentioned in some places to be very peculiar to be seen with sarcoidosis. Some people, they do have loss of appetite, but they don't have significant weight loss. So, ma'am, the generalized ill-being of the patient is much more than actual signs of the patient. But then the non-supportive findings is that once again we can't explain ileal ulcer. The patient does not have any cutaneous manifestations, does not have any lacrimal gland or salivary gland manifestations. Then in the investigation, The patient has anemia, which goes in favor of any chronic disease, elevated ESR also. Fibrotic shadows in the upper lobe of the lungs. Initially, we thought it could be pulmonary tuberculosis, but also we see that sarcoidosis people also have mostly upper lobe involvement of the lungs. Also, we saw peribronchial nodularity, and peribronchial nodularity, one of the differentials is sarcoid, after the all the infective causes. And also, this patient has a low normal PTH, which can to some extent go in favor of sarcoidosis, because sarcoidosis people, they generally have a lesser range of of parathyroid hormone. But the feature that does not goes much in favor is spondylosis of spine, or there is, the most important thing is there is no pre or paratracheal or any hilar or mediastinal lymphadenopathy, which is not what we usually see in sarcoidosis. And also there's no reticulonodular shadow. Normal serum ACE level can be possible in sarcoidosis, but for that we should at least have some clinical suspicion of hilar lymphadenopathy, which is also not there. So I can't say that normal serum ACE will still keep at this as sarcoidosis. And the patient also has low vitamin D3, which is not usually seen in sarcoidosis. They usually have a little more high, but towards the higher range. Ma'am, still, if we have to think about it, then we could explain it in terms of the stage 3 of sarcoidosis, in which they just have non-specific lung involvement without hilar lymphadenopathy. But for that, some additional investigation, like at least a serum calcium, or when we had already found the peribronchial nodularity, if we could have done a bronchoscopy with a biopsy of those peribronchial nodularity, it could have given us a histopathological evidence. Also a little far-fetched, but we could have done a gallium scan also, if we had to, if we had a strong suspicion of sarcoidosis.
All right. So on the basis of the history, the examination, and the investigations that were available with us, sarcoidosis was our first diagnosis. You are absolutely right. Low-grade fevers, scleritis, arthralgias, myalgias, the hoarseness of voice, mood abnormalities, everything fits perfectly into sarcoidosis as history-wise. History-wise, it is absolutely fitting ditto into sarcoidosis, and that was our first clinical diagnosis. You are absolutely right in saying that there was no hilar mediastinal pretracheal lymph node. So which means that for 1 year, patient has been harboring an extra pulmonary sarcoid. Most patients will have evidence of pulmonary sarcoidosis at the beginning of the illness or at some point during the course of the illness. Here for 1 year, there was no evidence of sarcoid. Even on the CT scan, there was no pulmonary involvement of sarcoidosis. So where was this sarcoid if it was there at all? We had no sign to tell us that it was there in one particular organ or organ system. We could not localize the sarcoidosis. There was no organomegaly. There was no raised alkaline phosphatase. There was nothing which was localizing the sarcoid to some point. You're absolutely right. Only 60% of patients with sarcoid have an elevated ACE level. 40% don't have an elevated ACE level. But just because of the absence of pulmonary involvement and the absence of a localizing area for the sarcoid involvement, we could not actually pinpoint where the sarcoid was. So you are absolutely right in keeping sarcoid as one of your very prominent and very high on the list of differential diagnosis. Perfect. Go ahead.
Ma'am, next up, ma'am, in a small, I would like to mention about autoinflammatory condition, though this case will not fit in that terms, because we did not know whether the fever was occurring in episodes or not. That's why we wanted to know whether the fever was episodic or it was continuous, because such autoinflammatory conditions, they usually present with episodic fever. They are like periodic fever syndromes.
Sorry.
So,
Sorry. Sorry. Autoimmune conditions. Is that what you mean to say?
ma'am,
Connective tissue disease,
autoinflammatory condition.
meaning?
Ma'am, autoinflammatory condition. Ma'am, like those familial Mediterranean fever and TRAP syndrome.
Okay. So that is that these conditions have to be considered much later down, isn't it?
Much lower
Once
down.
you have
Yes,
ruled
ma'am.
out, yeah, you're right. So we will not able to find out any of these. They did not localize to anything. and this did not offer any specific clue that it could be one of them. Perfect.
Yes, ma'am.
All right.
Ma'am, the only feature that was going in favor of it was scleritis and hearing loss, which is seen in one particular autoinflammatory condition. But the age is not of this characteristic. The pattern of fever is not of this characteristic, and the patient should have a history of prior episode. At least a family history should also be there. So this should be very low down on our diagnosis list.
Yes.
Uh,
Yes. Perfect.
Next, Alicia. Ma'am,
Okay, so
ma'am, this was one.
from here I would like to take on. So the next thing
Yes.
which the first of the DDs which we considered was sarcoidosis, inflammatory IBD associated arthritis maybe, but then after that we also explored the possibility of some vessel vasculitis, for example microscopic polyangiitis with granulomatosis. So the features which go in favor of Wegener's or microscopic polyangiitis with granulomatosis is that he had a history of low grade fever, malaise, generalized body pain, and the classical age group of this patient, he's 45-year-olds. These usually these diseases affect people in their fourth to sixth decades. And there was bilateral hearing loss which was partially relieved by Grome insertion, hoarseness of voice, which and there was pallor and scleritis. But again, the features which were kind of not in favor of this disease was there was no history of cough with expectoration, no history of any hemopsis, there was no signs and symptoms of any renal involvement in this patient, and there was no history of any epistaxis or any episodes of bleeding from anywhere. And the after investigations, few features which would still be in favor of Wegener's was there was anemia, there was raised ESR, there was an asymmetric hilar prominence which was said to be vascular, so it could be probably pulmonary hypertension due to pulmonary Wegener's. Or but then again, the features which we had no findings on CT and X-ray of any diffuse alveolar hemorrhage, any nodular infiltration of lungs, or any renal hypertension, or any and the abdominal ultrasound and other investigations in the abdomen also did not find any anomalies in the organs, any organomegaly, etc. was not there. Further, I would like to also entertain a diagnosis of lymphoma. So because the patient is having a low grade fever, some backache, pallor, malaise, non-specific signs, there was hoarseness of voice, which I initially thought was due to mediastinal compression of the left recurrent laryngeal nerve. There was loss of appetite, but it's been 1 year and there was no significant weight loss in this patient, no obvious lymphadenopathy on examination. Ileal ulcers, we thought that it was a presenting complaint and we could not explain ileal ulcers by the lymphoma, and no obvious lymphadenopathy on examination. And also after investigations also, the typical sites for lymph node enlargement were not present, no abdominal masses, no hepatosplenomegaly, no focus of any lymph node involvement was found, except for aortopulmonary lymph node was there was enlargement, there was peribronchial nodularity. So peribronchial nodularity, one of the important DDs after TB sarcoidosis, is also a lymphoma or a bronchogenic carcinoma. There was anemia, raised ESR, asymmetrical hilar prominence, which was probably due to the vascular cause again. Ma'am, this finding of vascular asymmetrical hilar prominence, we could not place it really anywhere. So that is one confusing thing which we found. And multiple myeloma.
So I would like to. Yeah, sorry. Go ahead. Go ahead.
Multiple myeloma
Go
is
ahead,
a very.
I'm sorry to interrupt you.
Ma'am, a multiple myeloma, we kept a DD at a very low DD because this is not the classical age group at which this presents. Also, there are no bony lesions on MRI, chest X-ray, CT, no hypercalcemia, no signs and symptoms of any renal failure. And but few points like a low grade fever, backache, malaise, abnormal AG ratio, raised ESR, multiple myeloma, we kept it as a very low DD. So a urine electrophoresis, serum electrophoresis could have maybe helped us in ruling it out completely. But if it is very low in the list, maybe it is not required as well. So these are my 3 DDs which I considered, maybe Wegener's lymphoma and multiple myeloma. But the patient's presentation is not
so good. So you have now
specific
come to the
associated
yes,
malignant
yes.
disorders.
So when you look at that list of Yes. So when you look at that list of conditions which can present as fever, the first was infections, inflammatory conditions, connective tissue disorders, and now you have come down to malignancies. Okay. So among connective tissue disorders, you thought of vasculitis, a small vessel vasculitis, microscopic pan, or vaginals. Vaginals invariably has upper respiratory tract involvement. Invariably, about 80% of them will have evidence of upper respiratory tract involvement. There was nothing to suggest that in the patient. The CT scan was also essentially normal. Some shadows here, there, query. It really did not highlight anything else. There were no respiratory symptoms and signs at all. Nothing. There was nothing localizing it to the respiratory tract. Microscopic pan invariably has renal involvement. The urine examination did not show any proteinuria. He had multiple urine reports which he was carrying, and we also couldn't find any proteinuria. In the absence of renal involvement, in the absence of hypertension, we really could not entertain a possibility of vasculitis. As well as SLE, rheumatoid arthritis, all of those goes. There was nothing on clinical features pointing to connective tissue disorders. There was no arthritis, so that ruled out a whole list of inflammatory arthritis. SLE, there was no evidence. He was a middle-aged male without any clinical symptoms and signs. Why would we entertain that possibility? So lymphoma, you're absolutely right. Again, in 1 year, they did not manifest at all. It is very strange and it is very unlikely to be any kind of a malignancy. He has not lost weight. Lymphoma has not led to any lymph node or extra lymphatic involvement. That again is very strange. And there is no evidence on your investigations, whatever you have of marrow involvement also. So that is also not there. And of course, myeloma, it does not fit into the clinical picture at all. All right. You have more DDs or you're done with your DDs?
A few more
So what are your
DDs.
final DDs, my friends? Oh, good. Go ahead.
From here, Bhavika will take on to discuss the further differential
Yes,
diagnosis.
Bhavika.
Ma'am, you already ruled out SLE and rheumatoid arthritis, so ma'am.
I have already ruled out SLE and RA, right? So I have made your work so much simpler. Okay. No,
Ma'am,
but
but
you
this
can
patient
consider
could
them
have,
if you have arthralgias and myalgias.
yes,
That
ma'am,
patient should
if
have
this
something,
patient
no?
could have,
No,
ma'am, fulfilled the criteria for rheumatoid arthritis, ma'am, but we do not have the history for exactly arthritis happening.
doctor, there is no arthritis, right? There was no
Yes.
arthritis ever. So without arthritis, you can't consider RA. You can still consider it if it is, say, 4 weeks illness or 3 weeks undifferentiated arthritis. But arthritis always has to be present. So there was no arthritis. So after 1 year to consider rheumatoid arthritis is a little unusual. It is not possible. We would not like to entertain it. Right? Similarly for SLE, we would not like to entertain it as a possibility. So you're right that in your differentials, it is coming as number 10, 11, and 12. So I would also keep it very low down on my differential diagnosis. Very good. What else?
Ma'am, the last one which remained was reactive arthritis, ma'am, but our patient does not have any history of any antecedent
No.
infection which would have led to.
Yes. And reactive has to happen in a temporal association with some event, and it has to happen
Yes,
immediately.
ma'am.
It can't happen and it can't continue for a year. So this cannot be considered. All right. So what else do you have? Yes.
Some
Other possible DDs, whole lot of them. Yes.
very far-fetched DDs include autoimmune hemolytic anemia secondary to RASLE, but again, then RASLE has been ruled out. Adult onset Still's disease, but because there was some RF positivity, but it is a very non-specific finding, and again, no arthritis and no rash. Additional investigations which might help us in ruling out or ruling in certain DDs include bronchoscopy for possible bronchogenic carcinoma or lymphoma, biopsy to see any vessel vasculitis and fibrinoid necrosis, but it is a lower down diagnosis, so just an additional possibility. Otherwise, mostly our DDs would be again, as Anesha said, we were very biased towards sarcoidosis, but investigations led us
Yes.
detract and sarcoidosis. But then we entertained the diagnosis of IBD associated arthritis and some connective tissue disorders we did entertain because we were not sure that was an arthralgia or an arthritis. The patient was just saying joint pains and generalized body aches. So we were like, if it was an arthritis, maybe we could consider some CTDs also. And, otherwise, infectious
So what are
disorders
your
were also
final two
somewhere.
diagnoses?
Yes, ma'am.
So Bhavika, what were your final two differential disorders, if I ask you? Hello?
Ma'am, if we were to narrow it down to
Anybody?
two diagnoses, we would
Give me
still
two.
keep
Give me two final. Yeah.
sarcoidosis,
Hmm.
and the next one
Yes.
maybe lymphoma, but I'm not. Second one, all of them seem so unlikely. So, a
Anybody
sarcoidosis.
else among four of you? Hmm?
Mom, actually,
Ma'am,
none of the DDs seem to fit in like exactly, or it's a pretty tough case.
ma'am, actually, ma'am, we were thinking like
All right.
this way
Follow.
that, yes, ma'am. Ma'am, we were thinking it
Hmm.
that this way that
What?
none of the disease strongly points towards any disease.
Yeah. So what would you do when nothing was coming out, working out? What would you do next? Tell me.
Ma'am, here we would want Ma'am, here we would want to say that a few of the obligatory investigations itself was not done in the patient. So, ma'am, if on the
Yes.
obligatory investigations, if something could have given us some potential diagnostic clues, we could have gone for it, because we can't be going
Hmm.
around doing blind tests for everything. So, ma'am, at least if we could have done a
Absolutely.
few more investigations in the obligatory set of
Like,
investigations, then, ma'am, like a blood
which is the
culture that
first
we
one you would
really
like to
wanted.
a blood culture? Perfect.
Yes,
Perfect.
ma'am.
Perfect. What else?
Ma'am, also we would want to get an anti-nuclear antibodies if we are ruling out for some autoimmune conditions,
Okay.
if at all.
And
Also,
ma'am,
ma'am, I would
serum
also
calcium,
serum
we were
calcium.
Serum
looking at
calcium.
sarcoid, so we did not do serum calcium.
All right.
Yes, ma'am.
Perfect. All right. Excellent. I must really compliment the four of you for having done such an outstanding work in interpreting the clinical history that was given to you and arriving at a list of differential diagnosis, which was absolutely exactly what the treating unit also entertained. See, a lot of these investigations the patient was carrying with him. All right. We did not get many of these investigations done. The patient came to us with 1 year history of fever, was carrying a whole set of investigations, including the X-ray and the CT and everything. So we were in that way that we did not have to get some of these investigations repeated or done at all. But this was what he came to us with, and we had to start from here, thinking what could it be. So if you can come down, you show me your obligate investigations.
And this was the slide.
That is gone. Yes, yes. So this is what we did first. Absolutely. We got repeated the hemogram. We looked for ferritin to see whether there was evidence of hyperferritinemia to show that there is an inflammation or an infection ongoing. We looked at the CRP again to see whether there was an infection. We got multiple blood cultures because IE was still a possibility we were considering. We did not get the electrophoresis done at this time because the AG reversal was there, but there was no other evidence looking for a blood dyscrasia. So we waited for that. LDH was mildly raised, creatinine was normal, electrolytes were normal, urea was normal. Repeatedly, creatinine came out to be normal. Urine was absolutely normal. Routine examination did not show any proteinuria. Microscopic examination was normal. There was nothing. Urine culture was normal. We did not do the ANA at the first go because remember, many times rheumatoid factor can be positive in up to 5% of patients beyond the age of 50. Yes. So before you attach an importance to rheumatoid factor, you have to really think whether you need that investigation or not. And I would like to highlight the fact that why was rheumatoid factor done in the first place in this patient? It was not indicated. See, sometimes what happens is somebody does a test and you are left with a positive report, and then you're left trying to interpret what happens with it, right? So The chest X-ray we got repeated, we got the ultrasound repeated, everything was normal. The Montu we did not repeat because he had already been on ATT and he had already had a Montu which was negative. So we did not repeat this. So after these investigations, doctor, we were left at the same situation that you were. That what do we do now? From where do we go from here? Right? So like you have given a list of differential diagnoses, we also entered in a lot of them, but a lot of them now would have required more invasive investigations, more expensive investigations, and investigations that were really not leading us in any way. Right? So we went back to do the simplest thing that can be done under this circumstance, and that is what?
Ma'am, history again.
Yes, absolutely. Perfect. We went back to history. So we went back to taking the history of the patient. We started from the beginning. What is your name? Where do you live? What do you do? So he had given us a history. Start on the first slide only. He was Mr. X. He confirmed his name. He was 45-year-old male. He was a resident near one of the in the peripheral areas of Delhi, not exactly in the central Delhi. And he was a supervisor by occupation. So we asked him, what supervisory activity do you do? What do you mean by supervisor? Right? So he says, डॉक्टर साहब मैं एक डेयरी फार्म का सुपरवाइजर हूँ, वहां 30-40 भैंसे हैं और मैं उसको सुपरवाइज करता हूँ. So his interpretation of the supervisor was that he was a caretaker of a dairy farm which involved poultry as well as buffaloes, cows, and there was milk related activity going on in that. So when we went back to this history, you went through one of the differential diagnosis, doctor, which was?
Brucellosis.
Brucella.
Yes. So when he told us what he actually did, the supervisor, my PG said, ma'am, he's a supervisor. He said, okay, supervisor. We thought maybe he works in a factory or something, but he was a supervisor at a dairy farm where there was a lot of exposure to animals, animal products. And then we really thought that maybe this is all brucella. And then when we went back and looked at the history, the examination, the findings, we found that a lot of these symptoms happen in patients with brucellosis. If you could go back to your brucella slide, poor thing, it was only 2 lines because you also
Ma'am, we had
went.
the history of exposure.
Yeah, yes.
Ma'am, actually, I was not even putting it
Exposure
here.
nahi tha na?
हाँ, I was not even putting it. I just put it. मतलब literally ऐसे a lot of my friends convinced me. मतलब the presenters that you should put it. You should put it. I was
Now
like,
do.
no, it's not possible.
So we
So
also,
yeah.
patients who have long-term fever and have a history of exposure to animal or animal products, they can have in about 20% scleritis is known. Low back pain is a common feature. Arthralgias, myalgias are a common feature. These patients can have hoarseness of voice. There are some case reports where recurrent laryngeal nerve paralysis have been described in brucellosis. So based on all this history and examination findings, which were not pointing to anything else, remember, we were not getting a pointer towards any other diagnosis. And the history pointing towards history of exposure to animals and animal products and milk products reaffirmed our possibility that can this be brucella? And the patient was from a peripheral village area, ruralish part of Delhi, not exactly central Delhi. That again made us think maybe it is brucella. And so then when we sent the blood cultures, like the girl said, ma'am, you must send blood cultures, you must send blood cultures. You're absolutely right. We sent blood cultures and we also sent some antibody tests towards brucella, which came out to be highly significantly positive. We started the patient on treatment with brucella, and within 4 days, patient became completely afebrile. So remember, why I am trying to point out this case is to highlight certain features. Long fever or prolonged fevers are very common, and you will encounter them across your life in many situations. Number two, there are many investigations that people order that confuse you more than they help you. The rheumatoid factor put you off on a completely different track. Why was the RA factor done? We don't know. In a 45-year-old person, 2 to 4% of people will have a positive RA factor. And as one grows older, the RA factor positivity becomes even more. So that if in an 80-year-old you get an RA factor done, in 15% of them, the RA factor is positive. The ANA should not be done unless you really suspect a connective tissue disorder, because interpreting an ANA in such a situation becomes a very, very difficult prospect. Always think of infective causes in India before you go on to malignancies. She was right in pointing out that we should look for solid tumors, we should look for lymphomas, but the CT did not pick it up, the MRI did not pick it up, the ultrasounds which were done did not pick it up, and we were not able to localize a solid tumor anywhere. Inflammatory conditions were unlikely because there was no evidence pointing to inflammation where we were not able to get it. Sarcoid, you are absolutely right. Sarcoid was high on our priority. We were just about to start him on a presumptive treatment of uh, steroids, because that's what we would have done. There was nothing else to do except start him on a short course of steroid to look for clinical response. Short of that, we decided to go back to the history and look at him once more before we went ahead and do start him on steroids. But I must compliment you on an excellent presentation and very, very, very accurate, in-depth analysis of the case. Wonderful, wonderful girls. All four of you who were so readily agreed to participate and volunteered to participate. This is not a simple exercise. This is a very difficult exercise. And I'm so glad that four of you did it. I hope you learned in the process of this. That is what is most important. Correct?
Yes, ma'am.
Yes,
Thank you
ma'am.
for the challenging case.
Was
Yes,
such
ma'am.
was really a bouncer. We never really thought it could go in that direction.
Yes,
So
ma'am.
thank you very much for all your participation. I wondered if anybody else has any questions, but I don't see anything else on any chat box anywhere that anybody else has any questions. So if there are no other questions or comments, thank you girls once again. And I think we will end today's session here. All right? Is that all right?
Yes, ma'am.
Yes,
Thank
yes,
you,
ma'am.
ma'am.
Thank you so much, ma'am.
Thank you
Thank you
very
so
much.
much,
Thank
ma'am.
you very much.
Thank
Bye
you,
bye.
ma'am.
Bye, ma'am.
Good afternoon, ma'am. Bye, ma'am.